founder member of ACIMR, organized member of ACI, founder member of WLNC, author of book Giant Cranial Aneurysm, a case-based atlas of imaging and treatment, a wonderful book. He contributed almost 14 book chapters in different books. He published almost around 178 articles in different renowned journals, and he has a lot of presentations and lot of about 400 lectures in different sessions. So we are happy, we are lucky, and we are grateful to Professor Nasikota to have us, amongst us, to teach us with his today's presentation on cerebral aneurysm management. So now I am requesting Dr. Shafiqul Islam, who will moderate the session. Thank you very much.
Thank you, sir, for your time and everything. Whenever we seek any help, you're always there to help us. So at the outset, I'd like to thank you very much for your time and everything. So without wasting time, I'd request Professor Nasikota to start his talk. For what we're waiting.
Hello, do you see my presentation?
Yes, sir. Yes, yes.
Oh, good. Thank you for invitation, friends. And I may say that I got the very fantastic hospitality in Bangladesh visit also. Either in hospital or outside of the hospital. I had good memories during fishing, during eating, during chatting with the colleagues. Really, it was good. I hope you are all good in that awful COVID situation. So let me start my presentation. Today's topic is the complex shape aneurysm treatment strategies. What is the aim? What is the aim of the treatment? Actually, the aim of the treatment is basically take the pressure gradient across the disease wall of the sac and the neck. And we need to enhance healing reaction to prevent rupture and regrowth. That is important. What is in that the sac and the neck, because the disease actually on the neck, on the vessel, not in the sac. By the way, I heard the knee sounds from you. Could you stop the sounds? It will be better for me. Thank you.
Sir, I have stopped the sound, sir. You can carry on, sir.
Thank you very much.
Thank you.
Because I'm hearing background sounds from you. Thank you. Okay. That the treatment options for aneurysm, as all you will know, endovascular and open surgery. For endovascular treatment, we have different options for treatment. The very first one is the parent artery occlusion. And then we have a big experience all around the world, occlude the saccule and treat the aneurysm. And then the last decades, more than the last decades, actually for me, it is 2 decades treatment option, is the hemodynamic mentality. Let me start with the very classic treatment of the aneurysm. As you see here, the coiling is not easy for wide neck complex shape aneurysm here. It looks to everyone that it is a simple parophthalmic segment aneurysm. Actually, it is not a simple aneurysm. You may put some coil, but it is not a real treatment. You will understand why. This is a ruptured case, female, and as you see, the coils are prolapsing into the parent vessel, and very nice technique, which is balloon remodeling and coiling. When you look at these coil shapes around the balloon, this is real remodeling of the coil. And what that means, that the beak here means the dog ear of the aneurysm sac. When you look the balloon in place and the coils is covered, whole possible problematic part of the aneurysm. Okay, let's follow this case. Is a year follow-up, no regrowth, stable. Actually, when you look the longer follow-up, it is 15 years follow-up, still no regrowth. It is obvious that especially in the ruptured case, especially if the major part of the parent artery has disease, there is a kind of regrowth rate. But if you occlude and focus on the dog ears, and it is also the principles of the open surgery, you need to take care of the dog ears, and then you will have a better healing and better follow-up period. Another case, ACOM aneurysm, the other A1 is absent. And as you see, the neck is really white, and the proximal portion of the A2 is incorporated with the aneurysm sac. And this technique is right now is 2 balloon technique. These are, I think this case done 2005. In case we will come to stent, in case you don't want to put the stent in certain medical obligation, you may still use the dual balloon remodeling technique for this. Again, as you see that the beak here created by us intentionally and occlude all the dog ears, you may have a total occlusion. This is the aneurysm treatment. Leaving some part of the aneurysm sac in such wide neck aneurysm is not a solution. It will come back you again. And again, if you have this type of long-term follow-up, you need to have a better occlusion rate. This is another aneurysm on the MCA for the same case. We realized that even simple parophthalmic segment aneurysm, we were using Onyx at those time. It is 2003. My resident drove these pictures. And this is Onyx cast. Again, one of the material for intrasaccular occlusion. And as you see, we, you may say you are crazy or not, but we are trying to occlude the dog ear. And then the time to time, we are having onyx around the balloon like a ring sign. And that's why in the follow-up period, of course, there is no regrowth rate. Look at that, how beautiful the parent artery reconstructed. Not because of the saccular occlusion, because of the dog ear or disease portion occlusion. It is more visible right now to mentality of flow diverter. So, while we are occluding the aneurysm sac, what we are doing? We are doing kind of a visible morphological treatment. I mean, visible part of the aneurysm treated with morphologically. Either for a coil, at the beginning we were using bioactive hydrocoil, whatever it is coils. Liquids, or right now it is the fancy devices are like Luna, especially for web. All of those things are aimed to save the day and also occlude the visible part of the disease, but non-visible part of the disease actually at the corner of the neck. Those are important for feature. What is the feature? Feature is the regrowth rate. When you look to published data, you can find a bunch of regrowth rate, and starting from 5% go up to the 45, maybe more. especially there's a lot of selection bias in these papers, especially when you look to very complex shaped large and giant aneurysm. Regrowth rate is almost for sure. So are we really doing treatment, total treatment, or are we really doing treatment for saving the day? We should ask that question to ourselves. Time to time, you don't need to force to have a total occlusion. I agree. You need to save the day, then you may reconsider everything secondary. For example, honestly, ask yourself, and if you coil it, this aneurysm, this is a siphon aneurysm, bilobule, this is balloon remodeling technique. If you leave it alone like this, what will be your recurrent rate? I believe every one of you clearly answered that it is high. But what is high? It all depending on the patient internal factor, internal healing reaction, hypertension, smoking, diabetes mellitus, and etc. So in those groups, when we first started to have the regrowth rate is getting higher, especially for complex aneurysm, we change our strategy and we aim to put another metal in the parent artery. At the beginning, I used coronary stent. I was one of the first group. I'm in the first group to use coronary stent in the brain. And but it was technically difficult. It was the stiffness of the stent create the problematic navigation for those cases. And then that the company work on it, and then we got the Neuroform and Enterprise, which is actually used for intracranial aim. And that is it. This is the coiling with balloon remodeling and then the stenting. What is the meaning of stent here? Because we already occlude aneurysm. The meaning of the stent is to help the healing reactions, means intima and subintimal factors, go over the metal, which is already occupied in that segment, and then create a new intima. And that new intima they give us a less regrowth rate and better healing reaction like this. This is 2009, immediately after treatment. And this is 2011. Look at how nice reconstruction of this ugly shape aneurysm. That's what I mean. Another very large aneurysm right now, if everyone has this with an unruptured period, they may easily put the flow diverter. But to come to that point, we pass those steps. This is again the balloon remodeling technique, 2007, and then stenting. And then look at that, this is 4 years later, aneurysm is not feeling. That segment, it is still a little bit enlarged, but it's good. Especially when you look to total results of very wide neck, ugly shape aneurysm, after 4 years, this is a success. The aim of me is to give the message, especially for young physician or less experienced center. You have a lot of tools right now. At the beginning, we hadn't got. Now you need to learn how to choose your technique, how to choose your material, how to use it on a specific particular case. Another case, the right MCA aneurysm, non-ruptured. As you see, the lower branch of the MCA looks close to the neck and bifurcation, but the upper truncus is proximal portion of the upper truncus actually in the aneurysm sac. So what I did here, this is the septal balloon, 3 markers, and I'm coiling it. This is a typical balloon remodeling technique. After occluding totally, as you see, there is a total occlusion. This is the treatment. Don't leave any part. Don't trust any part. And then I decided to put the stent because the flow here doesn't look to me proper. And then I want to create a whole healing in that segment especially. And then the technology leave us to use the low profile distal braided stent in that location from the balloon into the balloon. And then this is the scepter dual lumen balloon allow you to use the stent without changing, without doing exchange manipulation. This is the stent deployment, and this is immediately after stent. As you see, the flow totally turned back normal, and the lower branch is okay. There is nothing filling the aneurysm sac. This is a proper, perfect strategy for bifurcation, especially for bifurcation aneurysm. Don't forget the bifurcation has a constant hemodynamic stress in any case. You may use a stent to help you. If you don't want to manipulate distally, especially in that curved vessel, you may use the one proper vessel, and it's deploying the stent, especially for braided technology, let you have this shape. First, you need to choose the little bit oversized stent. And while you are deploying it, when you come to the neck, you need to push a little bit all the system to create that shape. What was this aim? You need to protect this one if you don't want to do Y stenting here. Because Y stenting here can be problematic. You need to manipulate it. With a single stent, you can easily see the neck protected by single stent and your catheter already in. And this is the coiling. Before stent, as you see that the coil is prolapsing, it's clear. And these are the coiling procedure, and this is the occlusion of the aneurysm, and 2 years follow-up. When you look at AP view, it seems that there is a regrowth, but actually when you look the oblique view, that is because of that curve of this vessel, and you may right now understand why I didn't do the Y stenting. And but single stent, you may remodel the flow. Also, you may occlude the sac properly with the coil. This is another strategy and another technique for complex shape. Let me show you why we are so afraid of regrowth. This is a case came to me with a rupture of left MC8 3-lobulated aneurysm, and I did a balloon remodeling technique, and then I saved the date. I occlude the aneurysm properly. As you see, the bifurcation is visible, aneurysm is gone. And what is it? Okay, I will come back again. This is 6 months later, something as you see here, regrowth. And this is a year later. You see that the middle lobule is becoming large. And this time I decided to do the Y stenting technique with 2 enterprise. And I did it. And I coiled that regrowth portion. You can understand why I'm saying 3-lobulated. This is because of it. And these coils are previous coil from the first treatment. This is a year later. And then what I did by doing Y stenting, this is already decided before taking the patient to the second treatment, by the way. I didn't decide this technique during the operation. That's why I prepared the patient with anti-aggregation, and I talk with them, with the family, why I will do it. Because you have a ruptured aneurysm, you have a regrowth in the bifurcation in a year. That is saying to me, you may have a re-rupture again if I left this portion like this. Or if I coil it again, I just coil the sac. I'm not attacking the real disease portion of the bifurcation. That's why I choose the Y stenting to cure this bifurcation. And by doing so, let's look at the angles of the upper and lower truncus. You can see the angle before and after Y stenting. Okay, this is after second treatment. As a summary, ruptured, first embo with balloon remodeling, and then this is immediate 1 year later after the first treatment, and then second embo by stenting and coiling, and this is 1 year later than the second stent. Look at this angle. Do you have any suspicions to have a regrowth here? And this is third year follow-up, and this patient is still good in shape. Let me go back this slide. Sorry. When you look at in general what is the stent indication, especially all the stent indication, mostly to prevent regrowth and getting better healing reactions. Also, I will show you to use the power of the hemodynamic. These are my mentality for stent indication. Those are obvious, but you will understand what is the power of hemodynamic. And you started to get a clue why I'm really focusing on dog ear. And let's continue. Another case, MCA, distal MCA, fusiform aneurysm with a typical angle from the left side, sorry. And then again, this is the balloon remodeling, coiling, and stenting technique. As you see, the coils are going around the stent. And again, look at the angles of the MCA. You cannot change the angle with balloon. For this case, the angles of the vessels, hemodynamic power is a big factor creating the aneurysm. That's why just occluding the visible sac and leaving it alone means that you are letting the local factors is working on to create another aneurysm. That's why the treatment mentality should contain something to change the hemodynamic factors locally. You cannot do it by surgery. By surgery, it is impossible to change this angle. And some of the colleagues are against to change the vessel morphology. But actually, I'm totally working on it. I love to see the distal vessel angle change. This is the follow-up. Look at that. There is no angle in the MCA right now. And the stent lets all the healing reactions with preservation of the lenticule artery and inferior temporal arteries. How I came to that point, and this is not a new mentality. Actually, we created in Istanbul, and we are showing those cases everywhere. Maybe some of you remember this case. This is an unruptured aneurysm and partially thrombose embedded in the diencephalon, located in the left internal carotid artery. Okay, you can call it. You can put something in the saccule, but how about the neck? How about the bifurcation? This is the bifurcation. A1 is here, and then the proximal A1 is already has disease. And can you able to touch this? It is not easy to put something here. And at those years, this is the stent-assisted onyx treatment. I put the corner stent in the middle because we hadn't got any other stent. It is 2000. And then I put onyx liquid. And I stop here to prevent the reflux and go into the lenticule artery. By the stenting, something changed here. What is it? The angle. The left anterior cerebral artery is feeling from the right ACOM. There is no fear about it. Look at this. There is no bifurcation there anymore. This is not the job of onyx or intrasaccular material. This is the job of stent. And the story is immediately changed. You have a giant aneurysm, intraparenchymal prolapse, partial thrombose, very wide neck and complex, even at the bifurcation. What will be your recurrence rates if you treat with another technique? Surgery is an option, but not a good one. And now it becomes a sidewall aneurysm, not anymore bifurcation aneurysm, and there is a healing reaction between the stent and the neck. Do you expect any regrowth here? Actually not. This is a year follow-up. Patient is turned back neurologically normal. And this is 17 years follow-up. 17 years, guys. So we need to think about it. This is a very nice example, combination of intrasaccular material and hemodynamic treatment mentality by using stent. Whatever stent it is corner stent at those years, 20 years later, before. Now we have a better stent. So another case, complex shape, showing you my mentality. Very classical wide neck basilar tip aneurysm, and there is a PCOM here on the left, and we use the left PCOM to coil it. This is the catheter from internal carotid artery coming from the posterior communicating artery and laying down in the bifurcation. This technique, now you realize there are certain material just for this. But this is not a good technique, especially I prefer to use the balloon for it, not the stent, because stent, the material need to stay there. I don't like this parallel stenting in the bifurcation. Why? Because by doing so, again, you are not changing any angle. Actually, you are not eliminating the bifurcation. You are just occluding the cause and the aneurysm and putting this, the material here. Here, there is no material, but the aneurysm is totally occluded. What happened? There's a second month. Very normal. At this time, we use a stent and coil this part. 2 years later, then the second treatment, another regrowth here. Especially that regrowth, when you look to regrowth, the lateral wall of the filling portion has no coil. That's why it is prone to rupture. And that time I put a balloon in the previously deployed stent and intentionally occlude the orifice of the left posterior cerebral artery. I already know that there is a posterior communicating artery on the left side. Why? Because I don't want a bifurcation there anymore. Because it is bifurcation, hemodynamic factors is leading that regrowth. It is a big factor. I'm not saying that the only factor, but it is the big factor. Now, aneurysm is again totally eradicated from the circulation, and the orifice of the posterior communicating PCA is also occluded. And now I was not expecting any regrowth. This is a 1.5 years later, stable. And this is 8 years later. There is no aneurysm filling, but interestingly that the posterior cerebral artery P1 segment started to fill. Should we have fear after 8 years of the third treatment? Altogether is something more than 10 years. Maybe you should follow this case. And this is 11-year follow-up. Again, very stable occlusion. And again, that the orifice of the P1 is still filling. But that eventually, what you are doing in that malign behavior of the basilar artery, the patient had a stroke after 11 years. That's why I did this MRI. By the way, I checked the angiogram. This is from cardiac emboli. Okay, this is the cardiac emboli. Okay, so another example from historical part of my career, and this is the case from 2000, where presented with left thalamic ischemic lesion because the aneurysm is located on the posterior communicating artery. That means it clearly explains why the patient has ipsilateral anterior thalamic infarction, because anterior thalamic artery arising from the posterior communicating artery, I already published this, that the isolated posterior communicating artery aneurysms, all of them looks like dissecting in nature, fusiform somehow, and then because of the dissection nature, there is an infarction in the thalamus. And basically, you may call it. It's easy to come here and call it. Or you may put a stent here and call it. Also, there's an option. You may put a balloon here and stent it, coil it, sorry. All these are options. Think about you are working in a hospital in 2000, 20 years ago, and you got this patient. This patient had the symptoms from thalamic, ischemia, and headache. That's it, no rupture. What I choose in 20 years ago, I choose hemodynamic mentality. That's why while I'm talking hemodynamic mentality, it is not a new one from that pipeline, silk, or frets period. It is something more than 20 years. And this is coronary stent in the posterior cerebral artery, shortest, smallest possible coronary stent, was a piece of wood. And it is diploid, it is balloon mounted stent of a Medtronic. Immediately after stenting, you see how the hemodynamic changed distally and how the feeling of the aneurysm also changed. But this is a coronary basic laser cut closed cell stent. It's not a flow diverter. That's why flow diversion is a misnomer. Every stent has flow diversion. And by we're saying flow diverter, everyone is understanding that the new braided stent technology and too many flow diverters in the market. And this is misnomer. Every stent has flow diversion effect. And second attempt of me on this case to put a single coil, just orifice of the posterior communicating artery. Look at the jet flow here. And basically one coronary stent and one coil. That's it, nothing in it. And let's follow this case. This is the 6 months. Aneurysm is occluded, P1 is elevated with an intimal hyperplasia in the stent. Continuation of the antiaggregation 20 years ago, by the way. And then 1 year later, aneurysm getting shrink, intimal reactions is actually having less stenosis. And also 5 years later, all this P1 is remodeled with a no aneurysm feeling. This is the 12-year follow-up of this case. You can easily appreciate the thalamic ischemic gliotic lesion. And then as you see here on the MR, contrast enhanced MRI, there's nothing feeling. And it's very stable treatment by using hemodynamic mentality with a single coronary stent in a proper segment and a single coil to prevent the jet flow anteriorly. These strategies is actually very important to have a proper selection of the technique. As I tell you before, any of you, any of a physician can choose other technique for than this one. This is kind of a, you know, while you are going from job to home, you are selecting certain ways because that ways may have a less traffic jam or you are enjoying to go that ways. And then everyone using a different ways. Someone goes by train, someone goes as the public transport, someone goes by car with a different way. This is the selection of the technique which is created by the physician mind. Let's get again more complex MCA aneurysm with the very ugly angle of the upper and lower truncus. What would you do it? Someone say that I can clip it or I can call it. This is a bifurcation aneurysm, very ugly shape. When it's getting growth, that shape is always opening because of the mass effect and pulsation. And This is the technique, actually, we also published that the body wire technique for Y stenting to eliminate the angle of the upper truncus. And then after putting the two enterprise, and then this is the microcatheter in the sac, you can also eliminate that ugly shape angles of this particular case. And then you can have a nice occlusion. When you follow these cases, this is a second year follow-up. As you see, even though you change the angle, you did a good coiling, you may have certain regrowth of the neck still. That means that regrowth is not only dependent on the changing the angle or occluding the sac properly. There is other factors are doing so. And then in my experience, those type of things is mostly happening in giant aneurysm, especially very large and giant aneurysm. That means that the neck and the parent arteries pathology is actually more obvious than the smaller or middle one. Almost the same type of the MCA aneurysm. I couldn't pass through this tiny upper trunk. And then my first aim was the Y stenting, but look at the M1. There is an angle here, there is an angle here, there is another angle here, also there is another angle to go in. I tried a lot, but I couldn't do it, and I ended up to put the P conus to hold that the flower shape distal part of this assembly. And then after putting the P conus to protect lower and upper truncus orifice, and then I coil it properly. This is immediately after. Good coiling and nice coiling. The patient already have an anterior communicating artery aneurysm and a breast cancer. This is a year follow-up. A common aneurysm is okay, but that one that I put the P conus and then I coil it, there is a total regrowth. Look at the coil shape. And look at the edema, which is coming from the pulsatility effect of this regrowth aneurysm. As then almost the same size of regrowth in a year. The patient has headache. This time, that there is easy to coil it because there was a P conus there. And this time I put the pipeline in the lower truncus to change the flow and to eliminate the bifurcation. And this is the pipeline. And then this is a month later. See, the edema is regressing quickly because the pulsatility effect is gone and aneurysm is occupied by the coils, and upper and lower truncus are feeling here. Because of the stent, you cannot see easily here. So how would you treat this one? While we are talking about the complex shape aneurysm, this is a real complex shape aneurysm located in the ACOM location. There is simply no neck. And in the A1 and A2, both sides is actually coming off from the sac and just headache, no rupture. I did this case live in WLNC course in 2013. What was the mentality? The mentality is to cure this ACOM region. This is the mentality. That's why I choose the X stenting. X stenting means the catheter coming from right side and going to the left, and the other one coming from the left side going to the left. Two catheters in place, and then simultaneously you are deploying the stent from right to left, left to right, and coil it. This is immediately after coiling. As you see, the dog ears are still feeling. Let's follow this case. Look at this. This is a 6-month follow-up. The 6-month follow-up, there is nothing feeling. That is unexpected if you just do a single stent here or single coiling here or whatever you do here. You need to change with the hemodynamic. Another cases, the same location, same morphology, very ugly shape. And again, the extenting mentality. Okay, this is coiling. Let's follow this case. This is a year follow-up. what you are seeing here. As you see, this is a regular flow during injection. The right A1 feeding the left one. The left A1 feeding the right one. No aneurysm feeling because of stenting. This was the aim at the beginning. I have no fear to have a flow from the right to left. And that complex shape, a calm location, becomes again a sidewall aneurysm, not bifurcation aneurysm anymore. That is what I'm saying. You can use this mentality according to the anatomy. This is a second-year MRI. Look at this shape. Did you ever believe that there was an ugly shape aneurysm here? But for the MRI, of course, you cannot see the right to left and left to right fascia. Another case, again, this case is done in the WLNC 2019 in Barcelona. Again, the same location. You may try to do the H-shaped stenting or parallel stenting here. And it's all depending on the anatomy of the anterior communicating artery. This time, we use the fluid diversion here. This is silk vista, right to left, left to right. Don't forget, the critical portion is here. If you have enough coronary diameter, which can help to stand side by side, you may do this. If you don't have this diameter, please don't do it. You may use a single stand ipsilateral or single stand in the contralateral. For two stand, you need to check it in coronary section. The real diameter of the ACOM is suitable for it or not. If the patient has ruptured and then in an acute stage, what would you do with this aneurysm? As you see, the anterior cerebral artery is very spasmodic, and then the anterior cerebral artery circulation is actually have some kind of perfusion defect due to the vasospasm. And aneurysm is located in the callosal-pericallosal region with a wide neck. And what would you do? This was my strategy. I first come to the orifice of the A2 and then give nimodipine from microcatheter and eliminate the vasospasm a little bit and then quickly go in the aneurysm and coil it. And I didn't aim to have a proper neck healing here because I already decided to do a second treatment with flow diverter. As all we know that the callosal-pericallosal artery aneurysm has a big regrowth rate. Even most of them doesn't need any secondary treatment, but that regrowth rate in this location is really high. So this is immediately after, and I left the patient to heal from vasospastic period, and this is immediately after treatment. Even after nimodipine and occluding the aneurysm, by the way, when you coil the aneurysm, time to time you can see immediate relaxation of the proximal vessel, most probably because of the pulsation and the simulation of the perivascular nerves, and then the perfusion getting better immediately after. So this is the angiogram showing that the feeling portion after vasospasm period, I think 20 days later. And that time, as 20 days later, we are doing our second treatment by using flow diversion. This is Fred Jr. Immediately after Fred Jr., you can see the change of the angle here. Look at this angle and look at this angle. And dramatic change, the feeling of the aneurysm sac. And then, of course, you have a really nice healing reactions, even in that distal aneurysm location. This is the second month vaso-CT images with the metal reconstruction algorithm, vaso-CT. In the rupture state, especially for blister aneurysm, you need to create different strategies to treat them. Flow diversion and stenting is obviously have better chance to heal. And for such location with the baby, I prefer to put, this is a classical location of blister. You can see blister everywhere, but classical location is that the C1 segment, upper medial wall of the C1 segment. What my first strategy is to putting the stent half deployed and then putting the microcatheter in the parent artery and selecting this very soft coil and squeezing these coils by using expansion of the stent. I think this is, enterprise. And look at that, by doing so that the soft coil is squeezing and then turning around the stent like this and eliminating the bleb. And that is, I believe, preventing the regrowth. Because after stenting, you need to give the anti-aggregation, don't forget. And this is the immediate after, stenting and coiling. And of course, in that blister ruptured case, I'm doing an early angiogram to see what's going on. It is stable. And also in the follow-up period, in that stented case in general, I'm using a lot the contrast enhanced MR angiography because of the stent. You need to use contrast, otherwise you cannot see it. And another case, interesting one, came to us with a rupture, and then we found this morphology. And you see that that bleb and then the saccular aneurysm on the parophthalmic segment. I decided to coil it with the balloon remodeling technique. And actually, I didn't like this morphology. I talked with the patient and said that I didn't like this one. The patient properly healed and went to the home, and we decided to do this operation a month later, and we already planned for it. But one night the patient came at night, and I got a phone call with another rupture. And then it's 1 month later. Look at the change of that blister location. Actually, I believe the first one was also from here, not from that one. This is my fault. And again, I got that same technique. This time it is fret. That for this one, I'm choosing the retrievable stent to play with it. Any retrievable stent is good for this technique. Again, the softest coil, squeezing the coil by halfway deployed stent, and then coiling it properly, and then deploying the flow diverter in acute stage, and then loading the patient with anti-aggregation. This is another technique we can discuss. This is a year follow-up. The patient now driving her car, is good in shape. Actually, she came to me in Glasgow Coma Scale 7 in the second rupture. So this is a year follow-up. Look at how nice reconstruction of that disease portion. This is a kind of very critical and deadly pathology, which is dissecting a blister aneurysm, treated with intrasaccular material and the material which actually promote healing at the parent artery. That is a fantastic the mentality, because that blister aneurysm, as you know, there is a classification. When it's getting smaller, it is on the certain part of the parent artery. When it's getting bigger, it's go around, and at the last stage, it turns out to be a fusiform aneurysm. And how can you be sure that you are putting some material in that saccular component? That's why in any blister aneurysm, you need to think that it may easily become fusiform. And you need to think and change your mentality or select your strategy accordingly to this etiopathogenesis and behavior of the aneurysm. This is the patient itself, herself, sorry. Let me go through, because you all know that the safety of the flow diverter in acute stage, there are meta-analyses. Let me come to very distal aneurysm and very bifurcation aneurysm. What is the mentality and strategy? As you see here, this fusiform aneurysm located in the distal anterior cerebral artery, having two vessels arising from the sac. So the intrasaccular mentality cannot work here if you don't accept infarction here. And this is a simple flow diverter technique. It is straightforward vessel and a very nice preparation. And this is Fred Jr. and this is a 1-year follow-up with a nice preservation of these vessels there. And what would you do for this case? The MCA aneurysm previously clipped, but this is trifurcation, not bifurcation and regrowth. And a patient had an additional headache, a new headache, need to have treatment. So the intrasaccular occlusion mentality, again, is not working here because we have a better solution. There are certain problems for bifurcation flow diverter mentality. We may discuss it, but this is not the main topic of today. But you may choose a proper vessel to put the flow diverter. This is clip itself. And then the flow diverter is located in place. And this is only 1 month later. This is only 1 month later that a large portion of the aneurysm is getting smaller, and the clips is getting closer to the flow diverter. And this is a nice picture showing that in a very difficult trifurcation aneurysm can be solved by just only using hemodynamic mentality. How would you treat this one? This is a very complex MCA aneurysm with multiple lobules located in the upper truncus. Look at the angle of the upper truncus. Look at the aneurysm sac itself, and the lower truncus is somewhere here. What would you do with a proper technique? So if you have a mature strategic choices, if you have a proper technique to apply for the strategy, you may choose the best for you and patient, of course. And this is the pipeline is located in the lower truncus because the upper truncus has already that two types of two circular component, and the angles of this one is also ugly. And also this is smaller than the lower one. Hemodynamically, the lower one is dominant. That's why, and also that the main neck is also from the lower one. There are too many factors for selection of it. And what would you expect in the follow-up in this particular cases? There is also another aneurysm here in the M1. So very complex. Look at this. You cannot believe your eyes. That is a fantastic reconstruction of whole MCA without putting any circular material. And then you cannot beat these images with any other technique, including any other technique with surgery, bypass, and combination of something. And we already publish, and everyone is publishing that flow diverter mentality in bifurcations. We're doing a lot of patients, but I'm not saying every bifurcation needs that technique, because flow diverter in bifurcation of the MCA needs to know the background knowledge, needs to have a better preparation, better follow-up period, because there you may have some problems with the flow diverter. If the aneurysm morphology is suitable for wide stenting, single stenting, balloon remodeling technique, those techniques may be more better than this one. But for this particular cases, there is no other endovascular technique can beat this flow diverter images. Ruptured MCA dissecting aneurysm on the right. And at those times, the surgeons did a good job. Sorry. They clipped the aneurysm, they reconstruct the MCA and bifurcation with some parenchymal problems. Morphologically, they did good. with some infarction. But this is not a treatment, because by clipping, you are actually squeezing the visible circular portion from outside of the vessel. You're not touching and changing any in real disease segment of the artery. As you see, that segment after 10 years create almost the same size aneurysm. The patient has a chance because they found us before rupture. So again, the almost the same mentality, because it's a lenticule high reach area and bifurcations there. Now we are using anchoring and looping technique with 27 catheter. This is the longest thread. And as you see here, the thread is located properly. If I had a longer flow diverter, I wish to touch one of the vessel wall in the aneurysm sac instead of putting that flow diverter in the middle of the physiform segment, because that means you will have problems during healing period. You should accept so. Simply and technically putting this flow diverter is not means that you had a good treatment. You need to ready for follow-up. What is those problems? One of them is intimal hyperplasia. The patient came to us with a headache, just headache. Don't miss that headache and do an imaging. Don't send the patient to home. Just 3 months with a giant aneurysm treatment. And you can easily appreciate those type of things. Aneurysm is gone, that's good, but that's a very huge intimal hyperplasia, and that the residual lumen is like that. And it is really simple to do a balloon angioplasty and get rid of that problem. And then this is a 1.5 year follow-up with a very proper healing. So if you're not ready to do those things, then you can easily get complication for giant and very large aneurysm. So for this case, it's because of this hemodynamic mentality and healing. Of course, it is not easy to say that zero expectation for future, I mean, regrowth and any other problem, but that is, I believe, one of the best among the others. As you see in the follow-up, all that intimal reactions is gone. Please let the body work itself. Please let the healing reactions work itself with a controlled way. But unfortunately, we are not controlling the healing reaction. That's why I have a big expectation from metal surface technology. If you have a nice metal surface technology with a very controlled way of healing reaction, we may predict the results of our treatment, especially in that very complex cases. How would you treat this one? Ruptured, dissecting, MCA aneurysm. Bypass and surgery, yeah, you can occlude the M1, expect then very huge infarction in the diencephalon, technically feasible. And then also dissecting nature calcified, partially calcified wall. And nobody wants to touch it, and they send to us. This is the rupture point, I believe. And this is again the same mentality we created with the cover stent period, scaffolding technique with the bare coronary stent and the cover stent in the inflow zone, and we carry this technique to the new flow diverter stent. This is the long Leo, which is scaffolding healthy wall to the healthy wall, and then the real job is actually done in that silk. Silk is in the inflow zone here. Please note this narrowing here, actually depicting that this is a aneurysm is maybe because of the dissection. This is one of the morphological features of the dissection. This is the first day follow-up. Look at the dramatic change of the aneurysm filling. There is a narrowing here, ACOM is filling here. And then this is the second month follow-up. Look at this, aneurysm is almost gone with the slight enlargement in that segment. The narrowing of the orifice of the M1 is still there. with a small ventricular stride infarction here, but patient neurologically getting good. And let's follow more. This is the 30-year follow-up. Look at that, whole vessels remodeled, whole of them. And A1 is still feeling. And look at that, these are not vasospasm, huh? This is 2 months later. This is 2 months. These are the something in the vessel wall. What is that something? That something is squeezing the lumen, should be a hematoma, should be inflammatory reactions, should be a combination of it. And it we call the dissection for that one. And then that's why if you let the body work itself, if you let the hemodynamic help the subintimal factors, you may have a remodeling in this specific segment, especially in a very difficult segment of our arteries. And that you may appreciate that the ventricular artery arising from that disease segment. This is a total remodeling. It is amazing to see those things. The silk here and Leo here. And all the job is actually done by the silk. By using that short silk is actually, you are not covering the ACOM, anterocerebral artery, also anterochoroidal artery. That Leo is actually a carrier of the healer. And this mentality, I carry this mentality to create Fred. And then the Fred is almost similar mentality with that one. That's why I like Fred a lot. And in certain pathology, whatever we are doing, we are having less success. This is the physiform partial thrombose, basilar atherosclerotic aneurysm compressing the brainstem and hydrocephalus, creating hydrocephaly. And this is a Jarrah Pasha technique. We also published this before attacking the aneurysm. We are preparing the patient to doing a shunt operation and creating a window for further enlargement of the thrombose segment after treatment. We create a window by having occipitomy, occipital bonetomy. And so, and then this is the treatment itself. This is a flow diverter treatment covering whole segments from healthy wall to the healthy wall. This is the only way to treat those aneurysm, because when you put coil here, maybe it will work, but you cannot coil this portion because the ICA and all perforator of the brainstem is arising from it. Some of the physiform aneurysm you can occlude, but not all of them. But I agree, some of them you may have an coil, even or you can occlude the basilar artery if you have a collateral flow from posterior communicating artery, or you can reverse the flow by occluding proximal vertebral artery. And this is after ugly shape aneurysm. You need to follow these cases and look at them. Even though you did a technically successful treatment, that aneurysm continued to enlarge, compressing the brainstem more. And then a year later, this is also interesting. A year later, you may have such rupture. Let me show you a successful one, almost the same morphology, the same presenting symptoms, and same stent technique is 2014. And look at this 2017, 3 years later. There is still something feeling here, but the rest is gone. I think that is a nice picture. If you have this type of occlusion and remodeling, you may have less chance of rupture, less chance of problems. And when you follow more, 2019, 5.5 year follow-up, you can see a proper reconstruction and no feeling at all here. So those cases are actually half and half. When you just look at that diffuse form atherosclerotic basilar artery aneurysm. I'm not talking about other dissection, other location, other etiology. The last case in this talk, and then I will finish it. This is young gentleman presented with the pain and partial ophthalmoplegia in 2011, 10 years ago. This is the aneurysm located in the right cavernous segment without any thrombosis. And again, the same mentality. Combination in no thrombosis at all. And that's why I waited a little bit, and the second treatment done 2012 with another flow diverter. Two flow diverter, one Leo here. And now we got thrombosis. This is a month later than the second treatment. In 2013, he came to me in that morphology. Look at this. Two flow diverter, one Leo, doesn't cure that segment. And the feeling is still there. And there is also something here. What is that? That is the MRI. What is going on there? That is an onion shape enlargement of the infratentorial aneurysm, which is actually prolapsing into the temporal lobe, creating edema and having this type of shape. This is a typical enlargement of partial thrombosed giant aneurysm, which is actually not intradural at the beginning. And by just doing stents, I create a giant aneurysm, and the vasovasorum around it is making it actually large. And did a compression, and seeing that ACOM is visible. And last time we gave him a chance cure with another flow diverter. This is the third flow diverter. But because of the mass in the temporal lobe, we start to create seizure. Still some feeling here. And then 2 months later, the edema is gone. Look at that, the different age of thrombose in the sac. But there is still feeling. 3 flow diverter, 1 Leo there. What is going on? A year later, what's going on? The aneurysm is still growing up. I look at the jet flow in that stented segment. And this time I occlude the parent artery because the ACOM and PCOM is functional. Parent artery occlusion, that is actually made the aneurysm stop growing. And this is July 2018. We have no growth at all. So in that case, it's a typical failed telescopic flow diverter mentality. We didn't do a perfect cure because we created a mass in the temporal lobe and we couldn't eliminate the vasovasorum. And in that case, create a duct in my mind, especially for cavernous aneurysm. And you put that cavernous aneurysm in that presenter slide. And non-atherosclerotic young patient, if you have a good collateral flow, you may think the parent arterial occlusion. In conclusion, yeah, we're having a better technology in our hands. We are gradually increasing our endovascular indication. We're having more and more distal and complex cases, but there is no standard treatment for everyone. You need to create your own strategy for certain location. It is depending on your country. It's depending on your availability to reach the certain technique and your experience. And antithrombotic and anticoagulation protocol is another issue. We haven't got a controlled healing of the neck. In the future, by having the surface modification technology, we may have so. I hope we can get those surface modification technology help. We need further investigation for it. But altogether, the acceptable results is our actually driving force. Before ending my talk, I like to make you remember the WLNC is approaching next month, October. It is, as you know, because of the COVID, we will do the online webinar, and the registration is already open, and it is and also free. All registration is free of charge. I hope you will join us. We will do cases from Istanbul this year, 2 days, and we will select complex AVM, dural AVF, and complex aneurysm for you to discuss. Thank you for your attention. I'm ready to discuss with you if you have any other question or comments.
Sir, for the last around more than 60 minutes, we were actually spellbound with your talk. We learned a lot how to treat the complex aneurysms. Now, I'd like to take the opportunity to invite Professor Kanok Kantibogo, sir. He's our mentor. He's our guardian, actually. Honorable Vice Chancellor, Bangabandhu Sheikh Mujib Medical University. I know he was very busy today. He was in meeting with our health minister. So luckily we were lucky enough that we finally could manage that he joined us. I'd like to request Professor Kanok Bogo sir to say a few words for today's. We know he couldn't hear all the talk. Yes, thank you, sir.
Thank you, Dr. Shafiq. First of all, I want to congratulate Professor Nasir Kochar for his brilliant lecture. Though it was not possible on my part to attend the whole lecture, at the ending part I could see. I met him in Dhaka when he visited in Bangladesh, and
Yes.
at that time also I have experienced his wonderful lecture. In this pandemic situation, in this pandemic world, what he has presented is a very, very learning process for our doctors, for our neurosurgeons, and those who are interested in endovascular procedure. I want to congratulate him, and I am very much grateful to him for his important and learned deliberations. Thank you, Professor Nasiko sir, for your wonderful lecture, as well as Dr. Gaurav also, who has attended. Thank you. Thank you very much.
Thank you. Thanks.
Thank you, sir. So we'd like to give you a good news. We have a beautiful biplane cat lab launched in our premises recently in last couple of months.
Oh, great. Perfect.
We'll invite you when the COVID situation is.
Hope so. Hope so. Yeah.
Now I invite Dr. Gaurav Goel. He's our good friend. He's our old friend. Whenever we ask for any help, he's always there to help us. He's head of intervention, Medanta Medicity in Delhi. I request Dr. Gaurav Goel to say a few words on today's talk and any questions you have.
So thank you for inviting me, and I think as you rightly said, we were spellbound for an hour to hear Professor Nasi share his experience, and it was mesmerizing. So good to see you.
Good to see you. Good to see you.
I have one question, like, which, you know, it's always there in our mind. Like, you show some beautiful ACOM aneurysm cases and DACA cases. How do you decide, like, when to flow divert them and when to stent coil them? You know, this is the new confusion which has come now since we have like better devices. So how do you choose that?
That is a good question. That is actually point I would like to stress on. First of all, for flow diverter cases, flow diverters are for, you know, the high mesh stent and the bare stent. I'm using these sentences because I believe a young generation is watching us. So if you have a more metal in the parent artery, you need to modify your anti-aggregation protocol in the follow-up period. First thing first. So for flow diverter, I'm not cutting anti-aggregation in a year, actually. Some teams are cutting in 6 months and 3 months. I'm not doing so. I'm giving anti-aggregation for long. And if the patient medical history or situation is actually preventing you to use more anti-aggregation, like the gastric ulcer, like the expectation of a new operation for another reason, or toothache, and they need to do some operation for the oral surgery. And so those things actually orienting me so. But to focus on the morphology, by using flow diverter or by using the single stent in a calm region, you are asking in that very distal tiny vessel region, I have no fear to use both flow diverter and the base stent, because we have distal flow diverters right now in our hand. Fred Jr. and the Silvista and Medtronic also work on it. It will become another company also working on it. And Silk also they already have that smaller stent in the past. They modified and became the Silvista. So if I want to combine the stent with intracellular material, I prefer to use bare stent than the flow diverter. If the morphology doesn't let me to coil it or web it, and then you may simply play with the parent artery with the flow diverter without manipulating it so. Because this is all depending on your technical experience and morphology. If you take a morphology saying to you that there will be intraoperative problems because of the dual catheter or stenting or passing through, you may not coil it. You may use the flow diverter with a proper vessel selection. These factors actually letting me to select which one is which.
Okay, very interesting. One more question for you. Again, like same as in Bangladesh and in India, we still have a lot of enthusiastic neurosurgeons who still like to clip a lot. And we get this query, like especially for MC aneurysms, like instead of doing a Y stent or a complex web, they say like, why not clip? Like, what will be your approach to that? Like, considering the expertise which we have.
You know, I grown up in a country, that country has Gazi Yaşargil. Okay, and Gazi Yaşargil students. I grew up this country and they create those techniques with our teams together in that atmosphere. There is no other countries in the world that the surgery create the more pressure to the endovascular therapist. Because I'm not telling the Japanese, Chinese friend or some Americans one, because what when you look at endovascular therapists, most of them are surgeon already. So there is not a big pressure on it. So the answer for your question, first of all, if you select your strategy and show them really good results, they may get rid of their mentality of clipping. But if you don't actually aim to cure the neck of application, and your regrowth rate or your success rate is lower than the clipping, they are right. You cannot blame them because they are doing this clipping for years, more than us, at least double experience they have. By the way, MC and everything is very reachable for them. They don't need to do extra manipulation for it. That's why you need to show them your strategy, your technique in specific cases is less risky and more durable than them. This is the only way to convince and select the better treatment for certain case, for certain location, for certain country. This answer is not the same in India, is not the same in China, is not the same in Turkey, is not the same in America or Japan or Europe. It all depending on local opportunity, because the patient and family is searching for the best treatment in certain countries. But in certain countries, they have no other option. They're going in hospital, and the hospital physicians are selecting the best treatments for them. The patient has no right to move themselves to other parts. That's why this is a local factor, should be solved together by having a scientific discussion, by having a scientific consensus, by really involving all experience, all complication rate, all possible technical facilities in your hand, and then you give the service to the patient and your the hospital group together.
Yeah. So I agree with you completely. I think that is the best strategy to move forward. Dr. Shafiq, you want to add
Yeah.
something?
Yeah, since we are surgeon, we have both arms. We'd like to take many of the MC aneurysms by surgery. But basically, we try to consider whether the aneurysm is dissecting or not. If it is dissecting, then it is very difficult for surgery also, because disease is not treated, because it is a world disease. So many times we need to consider bypass also in order to eradicate the disease. So now I'd like to request Brigadier General Syed Jahirul Alam. He is head radiology and interventional radiology combined military hospital. Brigadier General Syed Jahirul Alam, you have any questions to Professor Nasri Kocha? Are you there? Salek, do you have any comment or question? Salek, how is Salek? Salek.
Yes, yes. Thank you, sir. It's a very nice case-based, elaborative session and very learning session for us. Actually, I have a small question regarding your setup and our setup is technically and instrumentally different. And what is your strategy or advice for using the hardware, the maximum utilization or the use as less as possible? That I want to know from you.
Could you repeat the last sentence, because it is not hearable.
Regarding the use of hardware, what
Hardware.
you, yeah,
Okay.
hardware, yeah, the maximum utilization or country like us, we can go with as less as possible. What is your suggestion?
You know, yeah, that is a problem. You need to have a better hardware to get that strategic treatment options. The best one, of course, you need to have a biplane. For treating very complex shape aneurysm, especially it is more obvious in AVM and AVF treatment, you need to have a biplane. There is no discussion on it. You need to create an atmosphere with your management system to have a biplane. That is first step. If you don't have the biplane, and you may select your strategy accordingly. Most of the aneurysm can be treatable with single plane. I agree with that. But some complex case, your complication rate may be higher just because of the uniplane devices. And you need to learn the technique how to use biplane, because it is not the technique you are pressing two tube and then they're getting X-ray, giving X-ray to the patient. When you are pressing the biplane, when you are using the single plane, this is a technique. But in general, it is my observation, most of the time people don't aware that X-ray doses, especially for that complex case. If you're not doing short, you are giving a lot of X-rays to the patient, especially the neurosurgeons. Radiologists are aware of it, but for surgeons, in general, I'm talking in general, please don't misunderstand me. Don't aware the X-ray cumulative doses to the patient. So hardware should be biplane, and then separate the anesthesiologist team, which is actually familiar with intracranial pressure change in endovascular treatment, familiar procedure, because in open surgery, they all observe what's going on. But in the vascular surgery, they need to understand what's going on the monitor, and they need to follow you. And then also the from the system, biplane system, right now, all the company serve you almost really nice hardware system. Every one of them is giving them, actually. They're good.
Thank you, sir.
Yeah.
There was a question from audience. How do you manage a large become aneurysms with third nerve palsy if you suspect that coiling wouldn't solve the third nerve palsy? How do you manage this?
You know, people always fear of putting material in the sac and creating more problem on the third nerve. But actually, yes, aneurysm itself creates a mass and compressing the third nerve. I agree. If it is ruptured, I have no fear to occlude it. If it is unruptured, it's different. If it is ruptured, I'm calling it. The aim is, if you have a total occlusion, you are reducing the pulsatility effect on the nerve. That is really big factors. At the same time, you can give the corticosteroid or vitamins to enhance this one. But in the unruptured aneurysm, which is compressing any nerves, you may select not feeling to the sac, and you may focus on the hemodynamic mentality. This is another technique in unruptured aneurysm. I have no fear to occlude and ruptured aneurysm, which already are actually creating ophthalmoplegia. Or if you have a chance to take it off, but with open surgery, this is another option. We should accept so. It all depending on your strategy.
Thank you, sir. There was one more question. In case of stent-assisted coiling of basilar top aneurysm, you did 10 years back. Now the patient came to you with recurrence. What you do in this era?
Tell me, you have a stent, you already have coil aneurysm in
10
the
years back, yeah. 10 years back.
3 years back.
10.
10 years.
10 years, yeah.
Okay. Well, that you may telescopically stent it. What I will use in those group, and I have no fear to inflate balloon in the previous stent. You may do a balloon remodeling technique in the stent and coil it. And then if it is a single coil, it is a bifurcation aneurysm, you may think to use the Y stenting technique. Or you may use another stent in the previous stent. Even you may use the flow diverter in the basilar tip. We just published our posterior circulation thread analysis with a group of physicians. You may read so that the complication rate is a little bit higher than the anterior circulation, but very acceptable rate with the proper preparation and the follow-up.
There is a question just now. Combined consideration of hemodynamic and occlusion techniques for interventional treatment of complex aneurysms. Can you read the question? This question from Pawan Sultania.
Sir, your sound is a bit little audible, sir.
Which?
Yeah, can you read the question from the chat box?
I just opened that chat box. I just opened. Combined hemodynamic and occlusion technique for intervention in complex aneurysm. This is not a question.
Comment, yeah.
And thank you for thanking me.
So, if there is no question, is there any other question from the audience? Just for a minute. I think I can take it as a last question from the audience.
Sir, can I ask sir a question, sir?
Please go ahead.
Sir, I'm a resident, sir, third-year resident. Sir, I have a question. Sir, what are the factors do you consider to choose in the vascular technique for a bifurcation aneurysm, like wave device or Y stenting or flow diverter or stent assisted coiling? So what are the factors do you consider to take the decision?
Actually, I gave examples to you in my lecture. It is not that you don't expect a simple, basic explanation for it. Too many factors, starting from patient health condition, and ruptured or non-ruptured, contraindication to give anti-aggregation or not. Also, your expectation for follow-up period. So you may just call it and leave it for the second the treatment. You may do stenting, any other stenting, single stent, Y stent, X stent, H stent, or but there is a very dangerous, very problematic understanding on flow diverter. What you are reading right now from the published data, especially most experienced group papers, is showing you the success of bifurcation aneurysm with flow diverter. Especially less experience or less volume center people, physicians, try to select the easiest technique for their patients, and they feel that the flow diverter is the simple, non-problematic, short treatment, and it can easily applicable for any bifurcation aneurysm. And they're not focusing on coiling. They don't know how to use balloon, and they afraid to use the two stand in the bifurcation, and they just put the flow diverter and get rid of it. That mentality is wrong. That mentality is wrong. That flow diverter should reserve for very complex, very wide neck, and the aneurysm which is untreatable with other techniques. As I told you, and that there is not a simple, basic answer for that question. It all depending on the multiple factors. It all depending on morphology. For example, if you are expecting a vasospasm, if you already want to manipulate that vessel, you may not want to use the stent in the acute period. There are certain extreme cases I like to use stent in bifurcation distally in the vasospasm period, because the stented segment is not getting spasm because of the stent, but not in general. So this question is the question we need to focus on our ability, on our technique. I strongly suggest every one of you, please learn simple coiling, learn how to use balloon remodeling technique, learn Y stenting, learn bifurcation aneurysm treatment with flow diverter or without flow diverter, even learn how to occlude the parent artery. And then after having those skills, it will be you find your strategy and find your best treatment in your local factors and your local patient's factors.
Thank you, sir.
You're welcome.
Any questions?
Sir, I have a question, sir. Can I ask, sir?
Sure.
Yeah, please.
Sir, in case of vertebral giant aneurysm, fusiform aneurysm, we know that no treatment is best for this patient. So in endovascular treatment, a lot of options are there. So which one is the best treatment option right now for this type of patient?
I missed some of your voice, but I believe you are asking the vertebral fusiform atherosclerotic aneurysm treatment options. Did that the question?
So which one is right now the best option right now?
I'm specifying it. Are you asking atherosclerotic fusiform aneurysm, or are you asking dissecting fusiform aneurysm? These are different.
Dissecting fusiform. Dissecting fusiform.
Dissecting fusiform, yeah, relatively young population. That is different. These are the cases we have a good results. And then the best option is flow diverter. And we already have really nice results with cover stent here. Our base stent and cover stent combination, telescopic combination cases is coming from more than 20 years. So the best way to flow diverter, put the flow diverter in the dissected part of that pathology. And you may think to occlude the opposite vertebral artery if it is come into that fusiform segment.
Yeah.
So it all depending on the anterior cerebral artery location. If you're able to occlude the contralateral vertebral artery, which is coming in and creating an endoleak around your stent, you need to occlude that portion, either from vertebral artery coming into the aneurysm or from the ipsilateral stent segment. The best option is that, especially if you have a dissecting period which has nothing arising from it. You can check this with your new system with the vaso-CT or dyna-CT angiography. And if you haven't got any expectation of perforators or important vessels, you may put coils around your flow diverter, like I show you what I did for blister aneurysm. Don't forget the blister aneurysm is also dissecting aneurysm, just a matter of size.
Thank you, sir. Now we are almost at the end of our presentation. I'd like to request our Honorable VC Sir, Professor Kanokkanti Borua sir, to give concluding remarks and conclude the session. Before that, I'd like to thank you very much, Professor Nachiko sir, for your time. Wonderful time we learned a lot. Thank you very much. Professor Kanokkanti Borua sir.
Thank you very much. Hope to see you face to face.
Thank you. Thank you very much.
Bye-bye. Bye-bye. Take care, guys. Take care you from home.
Thank you for your deliberations, wonderful deliberations. At the same time, on behalf of Bangladesh, we are extending our gratefulness and thankful to you for your this learned deliberations. Thank you. Thank you.
Thank you very much. Thanks. Bye-bye.
Thank you, sir. Thank you. Thank you. Thank you, sir.
Shobik, thank you very much.
Thank you, sir. অনেক ভালো হয়েছে, sir. Thank you, sir. Thank you. তো শেষ করে দিই, স্যার। Thank you. হ্যাঁ, thank you, sir. Thank you very much, sir. তাহলে শেষ করে দিই, স্যার। Thank you, sir. সালেক ভালো হলো নাকি?
স্যার পোস্ট মিটিং কোনো লিংক দিব স্যার? স্যার okay everyone, let me call it a day. Thank you for joining with us. Allah Hafiz.